So we can break down congenital heart diseases into two types, two large categories. One is a cyanotic heart disease. Cyanosis is cyan. Well, the color cyan is like a purplish color. So that's referring to that purplish bluish color that your body gets when you get deoxygenated blood shunted. So a cyanotic heart disease is shunting of right to left shunt. So let me change the color of my pen. So it's a right to left shunt. So right side of the heart goes this way for some reason. And then it goes into your systemic circulation into your body. So your body's getting this deoxygenated blood. And as you know by looking at your veins, you know that your deoxygenated blood looks kind of bluish through the skin. So that's a cyanotic heart disease. The other type of congenital heart disease is an acyanotic heart disease. And this results from shunting from left to right, left side of the heart to the right side. So you're shunting oxygenated blood from the left side and it goes to the right heart and goes to the lungs. So let's talk more about cyanotic heart diseases. There's 5 of them that we want to know about. And these are the 5 T's, which make it very easy to remember. Persistent truncus arteriosus, so it's one big trunk of combined vessels. There's a transposition of 2 great vessels, 2 great arteries. Tricuspid atresia. Tetralogy of Fallot, so tetralogy of Fallot has 4 different associated problems. And then you have total anomalous pulmonary venous return. 1, 2, 3, 4, 5. That's 5 words. Okay, and notice I wrote the wrong words. So let's start with number 1. This is persistent truncus arteriosus. So during development, you do have a truncus arteriosus, but normally it's going to divide into your aorta and the pulmonary trunk. But in this problem, there's a failure of that aortical pulmonary septum formation to divide the truncus arteriosus into the aorta and the pulmonary trunk. And so what's going to happen is you're going to get deoxygenated blood. Let's change that. Deoxygenated blood comes from the right side of the heart, and it's able to enter circulation, as you can see, as well as go to the lungs. And in here, you can actually see that the oxygenated blood from the left side of the heart can go both ways as well. But the key point here is that you're going to have deoxygenated blood going into your systemic circulation and diluting all that oxygenated blood. So now the blood in your aorta is not very well oxygenated, so that's how you get cyanosis. Next one is transposition of the great vessels. So the problem here is that each great vessel, so the aorta and the pulmonary trunk, arise from the opposite ventricle. That is, the aorta, as you can see here, is arising from the right ventricle, and the pulmonary artery is arising from the left ventricle. So they got switched. And this is due to failure of the aortical pulmonary septum to spiral. So if it doesn't spiral, the spiraling is what causes the aorta to go to the left ventricle and the pulmonary artery to the right ventricle. And now this can be lethal unless there's a shunt connecting the two, because as you can see, if you don't have a shunt, you have two contained systems where blood just goes in and out of the systemic circulation, and blood goes in and out of the lungs, heart, and so pretty much it's like a cycle where nothing happens. No blood is getting the systemic circulation blood is not getting oxygenated. So you need a shunt connecting the two. So it's, let's say, a ventricular septal defect that's going to allow oxygenated blood to come into the aorta, into the systemic circulation. Next is tricuspid atresia. As you can tell from the name, again, it's failure of the tricuspid valve to form. As you can see in this picture, there is no tricuspid valve now, so there's no blood that's able to flow from the right atrium to the right ventricle. And because of that, you're not going to get oxygenation of blood because blood can't get to the lungs. So you have to have ASD and a VSD together for there to be life. And you can see that that's going to cause the blood. That's going to basically create a pathway where the blood will be able to go to the lungs. Okay. Next is the tetralogy of Fallot. As I said, there's 4 different problems in the tetralogy of Fallot. These 4 problems arise due to a symmetric division of the truncus arteriosus. So the septum dividing the pulmonary artery and the pulmonary trunk and the aorta is going to be displaced anteriorly and superiorly. And what's going to happen is that's going to lead to, first, pulmonic stenosis. So as you can see here, this is stenosed. Actually, I need to close that up. Pulmonic stenosis is number 1. Number 2, ventricular septal defect, as you can see here. Number 3, you have an aorta overriding the both ventricles, so it's overriding aorta, as you can see here. And that's again because of that displacement of that septum that would normally divides the aorta and the pulmonary trunk. And finally, you're going to get right ventricular hypertrophy. And why do you get that? Well, hypertrophy is because you're pumping against higher pressures. You have a stenotic pulmonic valves, so you're pushing hard against that, and you're pushing against the aortic pressures. Remember, aortic pressures are much higher than the pulmonary trunk pressures. A little quick test on remembering that. Remember what was the aortic pressure in a normal person? It's around 125, and the pulmonary trunk, what was it? It's 25, so it's 5 times higher. So that's why you're going to get right ventricular hypertrophy. So you're going to get, the right ventricle is going to get buffer. Clinical features here of tetralogy of Fallot. Because you're getting this deoxygenated blood to the rest of the body, you're going to get dyspnea on exertion. So you're going to be short of breath because they're getting poor quality blood, so blood low in oxygen. The other thing they're going to get is they're going to get something called TET spells. Sorry, let's go back. And TET spells is acute episodes of hypoxemia, where the baby's going to turn blue, they're going to be short of breath. And this just happens once in a while because it's hypothesized that acute changes in position of the septum will cause increased pulmonic obstruction. Because note that normally you can have blood going through the pulmonic valve, okay? But if your obstruction worsens, then it's going to cause even more blood, more of this deoxygenated blood to go into the systemic circulation. So that's how you get these acute episodes of hypoxemia where the baby turns blue. And what the baby's going to do to relieve this TET spell is they're going to squat. And remember what does squatting do? Remember that? Remember, first of all, it increases your venous return, and second of all, it's going to increase your systemic vascular resistance. So that's the vascular resistance here goes up, while the resistance in the pulmonary veins is the same. So that, where is that going to send blood? That's going to decrease the impetus for the blood in the right ventricle to go through that ventricular septal defect, and more blood is going to go through this pulmonic valve. So you're going to get better oxygenation of blood and less dilution of your blood in the aorta with deoxygenated blood. This is our most common cyanotic heart lesion. So that's it. Now the next, number 5, this is total anomalous pulmonary return. So this is a problem where your pulmonary veins drain into the right heart circulation. And that's a problem because normally your pulmonary veins drain into your left atrium. So again, it's a loop where your oxygenated blood goes nowhere. It just keeps going in and out of the lungs, back to the right ventricle, and back to the lungs. So this can be lethal if there's no shunt that allows that oxygenated blood to flow to the left heart. So actually, because it's such a loop, your oxygenated blood's this stuff is gonna stay oxygenated the whole time because it goes to the lungs, comes out, goes back to the lungs. So you have to have a shunt that can bring this oxygenated blood over there. Or here. So next we have Epstein anomaly. This is also a cyanotic heart lesion. And the problem here is that your tricuspid valves, as you can see, are displaced. They're downwardly displaced into the right ventricle. So that part of your right ventricle becomes atrialized. So this stuff is all atrialized. It basically acts like an aorta. It looks like an aorta. Atrium. And your right ventricle is not going to work well because it's how small it is. And as you can see, now there's like a huge space between your ventricles, between your valves. So now you're going to have tricuspid regurgitation, as I've drawn in this picture. Let's change my pen. Tricuspid regurgitation. And because you're regurgitating all this blood, it's going to increase volume in your right atrium, and so it's going to enlarge as it's drawn in this picture. And a common cause about this is lithium exposure. So when the mom is taking lithium, the baby is exposed to it and they can develop this problem called Epstein anomaly. Finally, one additional thing is this problem is associated with the PFO as a patent foraminal valley, and it's also associated with conduction abnormalities. Because, first of all, you have an enlarged right atrium. So remember, when your atrium becomes enlarged, you can have arrhythmias occurring and you can have conduction anomalies. And because there's extra blood in the right atria, you're going to have increased pressure. And that's going to push against this wall. And remember that septum primum that normally closes that PFO? If you have increased pressure, it's going to open that septum, and you can get a PFO in the patent foramen ovale. So that's it for our cyanotic heart lesions. Next, we're going to go into acyanotic heart lesions. So remember we discussed this. This was due to left to right heart shunting. So oxygenated blood going from the left heart is shunted to the right heart and to the lungs. So normally our babies are usually fine because they're not getting deoxygenated blood into the systemic circulation. All they're doing is they're just returning oxygenated blood back to the lungs. Unfortunately, what this is going to do to your pulmonary vessels is it's going to cause volume overload because you're just putting extra blood into the pulmonary vessels. And what's going to happen next is you're going to cause increased pulmonary pressures and increased pulmonary resistance because of all that extra volume. And eventually, there's going to be so much pressure in the lungs. Let me just draw this out so it might be easier to understand. If you have increased pressure here, normally we were having oxygenated blood go this way. But if you increase pressures enough, remember it's all pressure gradient. So if your pressure increases over, let's say this is 1p, this is 2p now. Now you're going to reverse this shunt. Remember, if pressure goes down your gradient, so you're going to go this way. And now you do have deoxygenated blood going from left to right. And this is called Eisenmenger syndrome, when you have reversal of your left to right shunt becomes a right to left shunt because of that increased pressure on the lungs. So now, without further ado, the first acyanotic heart lesion is an atrial septal defect, which we've mentioned many times, but now we're going to get into little details of it. So this is a defect in the interatrial area due to a defect in the formation of the ostium secundum. Now I want to differentiate, because this sounds very similar to a patent foramen ovale, right? It's a hole between the two atria, allowing blood to flow between them. The key difference here in the ASD is that septal tissue is missing. There's a defect in the formation of the ostium secundum, so septal tissue is missing. In a patent foramen ovale, the only problem is that the valve flap covering the hole fails to close and fuse. Remember, we had that valve flap, and it fails to go this way and close. On exam, what are you going to hear with atrial septal defect? Well, we kind of mentioned this already. What you hear is a fixed split S2. And why was that? Remember, we have this increased blood flow going from the left to the right. So there's going to be a lot more blood in your pulmonary valve, in your right ventricle. So that's going to cause delaying of the pulmonic valve. It's going to be slower than the aortic valve, and it's going to happen in both systole and diastole because you have this high pressure blood from the left side going to the right side. So that's going to cause that fixed split S2. You can also have a systolic murmur from the pulmonic area. And why was that? I mentioned that briefly one other time. And it's the same idea. It's not because of blood flow across the septal defect. It's not because of that. It's because you have extra blood going through the pulmonic valve. And that's going to cause a systolic murmur. That's why it's systolic, because your right ventricle, it contracts and causes blood to go through that pulmonic valve in systole. Final thing I want to mention is you can have something called a paradoxical emboli. And that is a venous emboli entering the arterial circulation. That's paradoxical because you would normally expect the venous emboli to go through the right side of the heart to the lungs. But instead, your venous emboli, let's change our pen color again. And venous emboli can cross this septal defect in the middle and go into systemic circulation. So that's called a paradoxical emboli. So next one we're going to talk about is a ventricular septal defect. And this is the abnormal opening in the septum dividing the left and the right ventricle. It's basically the same idea as the ASD, except for this is in the area between the two ventricles. This is the most common congenital heart defect overall. Remember, we said what was the most common cyanotic heart defect? That was, remember, cyanotic was the right to left shunt. Remember, that was the tetralogy of Fallot. But overall, out of all the septal defects, whether they're acyanotic or cyanotic, this is the most common one. And there's a syndrome that is very oftenly seen together with. If you might have learned this before. If you do, try to remember it. If you don't, it's called fetal alcohol syndrome. And this is when not the baby drinking alcohol. It's when the mother was drinking alcohol while the baby was in the womb, while the mother was pregnant. And that's why we don't recommend mothers to drink alcohol when they're pregnant, because you can get fetal alcohol syndrome. Now, the size of your defect here of your ventricular VSD is going to determine your symptoms, which makes total sense. Smaller defects can be totally asymptomatic, while large defects, which are going to allow a lot of blood to flow through, are going to lead to Eisenmenger syndrome and heart failure. Remember what Eisenmenger syndrome was. Remember that was reversal of our shunt, and because of what? What was the underlying cause? It's because we eventually going to lead to increased pressures in the pulmonary area, and that's going to reverse our shunt. So finally, we're going to do patent ductus arteriosus. What is this? We mentioned this already. It's failure of the ductus arteriosus to close after birth. Because remember what was the thing that normally causes it to close? Remember that you usually have that decrease in prostaglandins when that placenta is removed. And remember that normally prostaglandins keep this alive. The prostaglandin E keeps it alive. So anyways, for some reason it doesn't close, so it's patent. So your shunt will be a left to right shunt because your pressures in the aorta are going to be higher than pressures in the pulmonary vascular, which is actually opposite of what it was in the kid. Just something to note. And on exam, do you remember what kind of murmur it was? If you saw the heart sound lecture, you would know. You would know it's a continuous machine-like murmur. So it literally sounds just like a machine in the background, like some washing machine running constantly. So it's constant in both systole and diastole. And this can lead to Eisenmenger syndrome as well. And what you're going to get is going to get late cyanosis in the lower extremities, but not the upper. And why is that? Now we have to look at the anatomy to understand why. Let me draw my blue colors. So now we have our right to left shunt. So what's going to happen is we have the blood in the pulmonary artery. It's going to come through this shunt, this patent ductus arteriosus, because we have reversed our shunt, and it's going to go down. Now this is the descending aorta, and the descending aorta is going to feed your lower extremities, but it does not feed your upper extremities. What feeds your upper extremities are these branches of the aorta up here, the brachiocephalic trunk, the carotid arteries, etc. So your deoxygenated blood is not going to go up there. It's going to come out the PDA, and it's going to go down to the descending aorta into the lower extremities, and that's why you see this characteristic finding. Finally, what was the treatment for this? I already mentioned this. Remember, what we treat is with indomethacin. And do you remember the mechanism of action? Remember, indomethacin is an NSAID that's going to block prostaglandin production. Remember, prostaglandin keeps it alive, so if you remove prostaglandins, your patent ductus arteriosus is going to close, and you have solved the problem. Alright, finally we have coarctation of the aorta. Now this is a narrowing of the aorta near the insertion of the ductus arteriosus. And that's why it's called a juxtaductal problem, because it's near the insertion of the ductus arteriosus, which was right here. We can remember we said. So it's going to narrow around here. And if it's not corrected, what you're going to see is you're going to have dilation of collateral blood vessels of the intercostal arteries that allow blood to reach the descending aorta. Because as you see here, if we block this area, we just block blood flow to the descending aorta. Blood can still go to the upper extremities. We just talked about that, remember? We can go through the subclavians, we can go through the brachiocephalic trunk. But if you have blockage, what you're going to do is you're going to have blood go through this subclavian. And subclavian has branches and collaterals. And the most important one is going to be these intercostal arteries, as you can see here. And these intercostal arteries are going to meet up with the aorta. So that's how you can get blood to the aorta, to the descending aorta, even when this part is blocked. Now, clinical features here are going to present with hypertension in the upper extremities and weak and delayed pulses and low blood pressure in the lower extremities. Again, that's all makes total sense. It's very easy to understand because you have all this blood can't go down to the descending aorta to the lower extremities, so you have low blood pressure there and delayed pulses, because there is some blood going to make it down, but it's going to take longer. And the majority of the blood, though, is going to go up into the upper extremities, into the arms. As you can see, this goes to the arms, this goes to the other arm, this goes to the head. So you're going to have increased blood pressure there because you have all that extra blood in there. And because we have these extra dilation of the collateral blood vessels, you can actually see that on the x-ray. You're going to see notching of the ribs due to enlargement of these collateral intercostal arteries that we use to adapt to get some blood to the lower body. Alright, so that's a wrap up for our cyanotic and acyanotic heart diseases. These are the congenital heart diseases.